On November 18, 2008, a research paper published in the European Journal of Heart Failure effectively silenced a medical treatment that had been successfully utilized for 67 years. This study involved 2,681 patients across 13 European countries and consisted of 24 months of double-blind, placebo-controlled observation. It represented the largest morbidity and mortality trial ever conducted on a botanical medicine in modern history. The headline result was featured prominently in the abstract, stating that the primary endpoint showed no significant difference between the herbal drug and the placebo. American cardiology professionals read this abstract and moved on. However, buried several pages later within the exact same paper was a completely different set of data. At the 6-month mark of the study, the patients taking the medicine were dying of heart-related causes 41% less often than the patients receiving the sugar pill. Statisticians noted that the odds of this result being a matter of pure chance were less than 1 in 100. A secondary look at patients with moderate disease showed that instances of sudden cardiac death had been reduced by nearly 40%. When the lead author attempted to present these specific findings at the American College of Cardiology, a senior cardiologist in the audience publicly advised him to take his own data with what he called a large sack of salt. The treatment in question was a plant that grows wild in 36 American states. It had been listed in the German Pharmacopoeia since 1941, approved by their equivalent of the FDA in 1984 and again in 1994, and had been prescribed by German cardiologists for 3 decades without any controversy. Despite this, the company that manufactured the standardized extract refused to market the product in North America. This is the account of a trial that actually worked, a conclusion that did not reflect the data, and a heart medicine that grandmothers in Europe still take every morning, while their American counterparts are sold a $2.5 billion pharmaceutical alternative. To understand why a successful trial was buried, one must understand the actual question the trial was asking. In the year 2000, a German cardiologist designed an experiment to answer a specific question. A standardized Hawthorn extract had been used in German clinical practice for a generation. Hundreds of smaller studies suggested it improved symptoms in cases of mild heart failure, but there had never been a definitive long-term mortality trial. He set out to create one. The study population consisted of patients with moderate to severe heart failure. Their hearts were already failing, pumping out only about 1/3 of the blood that a healthy heart would pump with each beat. These were not patients on the verge of trouble. They were patients in deep trouble. The trial enrolled over 2,500 of them. Half received 900 milliliters of Hawthorn extract daily, while the other half received an identical-looking placebo. Neither the patients nor their doctors knew which was which during the 24-month observation period. The primary endpoint was the time to the first major cardiac event. However, there is a detail that almost no one reported. Every single patient in the trial was already on the maximum medication regimen their doctor considered appropriate. At the start, 85% were taking diuretics, 83% were on common blood pressure drugs, and over half were taking digoxin. Most patients were taking 4, 5, or even 6 of these heavy pharmaceutical medications every single day. The trial was not testing whether Hawthorn worked for heart failure in general. Instead, it was testing whether Hawthorn added any benefit as an add-on for patients who were already maximally medicated by modern cardiology. This is a completely different question. In traditional German practice, Hawthorn was prescribed early as a first-line support, long before pharmaceutical escalation. The standard use was to slow disease progression in the mild to moderate stages. By the time a patient is on 5 concurrent cardiac drugs, their physiology is already saturated. There is very little headroom left for any additional therapy to significantly move the needle on a composite endpoint measured over 2 years. The German Medical Commission had explicitly approved Hawthorn in 1984 and 1994 for exactly the population the trial excluded: patients in the early stages of heart failure before maximum pharmaceutical intervention. That evidence was real and had not changed. In November 2008, when the trial results were published, the abstract reported that the difference between Hawthorn and the placebo was not statistically significant regarding the primary endpoint. American cardiology textbooks were updated to reflect this, and Hawthorn was filed under remedies that sounded promising but did not pan out. However, looking at what the same paper said just past the abstract, the data showed that at the 6-month mark, patients taking Hawthorn were dying of heart causes 41% less often than those on the sugar pill. This is not a small number or a coincidence. When looking specifically at patients whose hearts had not yet failed completely, sudden cardiac death dropped by nearly 40%. A year and a half into the trial, the Hawthorn patients were still dying 20% less often than the placebo patients. In March 2007, the lead author traveled to New Orleans to present these results at the American College of Cardiology annual meeting. He reported that the primary endpoint had not reached significance, but he heavily emphasized the secondary mortality findings. He concluded that the extract was undeniably safe and had successfully postponed cardiac death in patients whose hearts were still actively fighting. The session chair, Salim Yusuf, a respected clinical trialist, praised the trial's design, but then publicly told the lead author that any conclusion based on a subgroup analysis should be taken with a large sack of salt. He told the room the safest reading was that the trial was a good trial with an empiric result. Safe, but not effective. That was the message American cardiology took home. In Germany, however, doctors simply continued to prescribe Hawthorn. The official pharmacopoeia entry from 1941 was not removed. German general practitioners and cardiologists kept writing prescriptions for the exact same extract because they were not prescribing it to patients already saturated on 5 other medications. They were prescribing it earlier in the disease course, exactly as the original evidence base supported. The company that manufactured the extract made a quiet business decision in the aftermath. When asked why Hawthorn was not sold in North America, a representative stated that the company markets the remedy in Europe, but not in North America. This was not a regulatory ban. There is no FDA action against Hawthorn. It was a pure business calculation. The U.S. market for heart failure drugs is currently valued at $2.5 billion a year. The patent-protected pharmaceutical regimen American doctors prescribe generates that massive revenue. A standardized plant extract sold over the counter generates almost none. This is the true suppression in this story. It is not a banned medicine. It is a medicine that was simply never offered. It was tested once in conditions that could only fail, reported in a way that hid the true result, never marketed by the company that made it, and never adopted by a cardiology establishment that read the abstract and moved on. There are deeper reasons Hawthorn works that the trial confirmed without naming them. The standardized extract is concentrated in plant compounds that gently relax blood vessels and improve blood flow through the heart. Modern science now understands that these compounds tell the cells lining the blood vessels to behave more like the cells of a younger, healthier person. German doctors had observed this clinically for 60 years without knowing the cellular mechanism. Patients felt better, climbed stairs again, and walked further. The molecular explanation came decades later. That mechanism is the exact opposite of how pharmaceutical heart medicines work. Chemical drugs block an enzyme, block a receptor, or aggressively force fluid out of the body, targeting specific pathways by force. Hawthorn does none of those things. It supports the cardiovascular system the way good food supports it, gently, over months. This is exactly why it was tested as an add-on, and why the result on the primary endpoint was not dramatic. What the trial did show, in the data the abstract refused to mention, was that even when added on top of maximum pharmaceutical therapy, the plant measurably reduced sudden cardiac death. In Europe today, a German pensioner with mild heart failure can buy a box of this Hawthorn extract for about €15. Her cardiologist or general practitioner likely approves of it. The 2008 trial sits on a shelf, understood for exactly what it was and what it was not. In the United States, that same pensioner is offered a different path. One pill, then another, then a diuretic. Each requires regular blood work and carries side effects that often require additional medications. The medical system bills steadily, and the disease progresses slowly. The tree that produces the medicine still grows wild in 36 states. The berries ripen in late September, and the flowers bloom through June. A patient wanting to know what 80 years of European cardiology has known would not have to wait for an American clinical trial. The evidence already exists and is completely published. The numbers are real. The interpretation that buried them was simply a choice. Outside American cities, on roadside hedges and old fence lines, the same plant German physicians have prescribed for 3 generations is in bloom right now. The pensioner in Stuttgart and the pensioner in Cleveland are looking at the exact same plant. One was told what it was, one was not. If this information changed how you view clinical trials and medical history, do not let this knowledge be forgotten. If this story changed how you look at the plants in your own backyard, please subscribe to the channel and like this video. We are uncovering the history that has been overlooked. Help us grow this community. The next discovery will be shared soon.